Hello, Dr. Vicky.
Good evening.
Good evening. Should we start?
Yes, we can proceed. It's 5 o'clock.
5 o'clock. Okay. It's good evening here, Dr. Casián. It's good morning there.
Hello, good morning from Mexico. Good evening for you.
Yes. So my name is Advance, Dr. Chingwena. I think I was speaking to you for the coordination. I will start off with just some brief introductions. Welcome, docs, to the Zimbabwe Dental Association Annual Congress. It's our pleasure to welcome you to give a talk to our association. Colleagues, I will start off by just a brief introduction. Dr. Jorge is from Mexico, Orthodontist. His background, he trained in pediatric dentistry in 1988, Mexico City, and also orthodontics. He's a professor of the Mexican Dental Association since 1991. He's an author of multiple publications and is a frequent international speaker. I think for those of us who attended the recent IAPD Congress, he was one of the speakers at that Congress. He's a member of the International Association of Pediatric Dentistry, that's the IAPD, also the Mexican Dental Association, the Latin American Association of Pediatric Dentistry. I think his big interest is in developmental defects of enamel. I started following Dr. Casián more for his work and publications on MIH. So tonight we switch the topic from implants to pedodontics. Over to you, Dr. Jorge.
Okay, thank you very much. I would like to start saying thank you for this invitation. It is a great honor for me to be here with you today. I'm going to talk about two different topics, but they are linked in some place. The first topic is aesthetic restorations in pediatric dentistry. I'm going to focus this part of the lecture in pediatric zirconia crowns, how and when. And the second part of this presentation will be about developmental defects of enamel. Especially, I'm going to talk about restorations in hypomineralized first permanent molars. So my name is Jorge Casián from Mexico. This is my clinic. That is my waiting room area, and that is my operating room. I have been working as pediatric dentist as an orthodontist for more than 30 years. In Mexico, of course. Natural teeth are beautiful. And as dentists, we know that there is no restoration that could improve the beauty of natural teeth, especially for those details and imperfections that makes them unique. In Mexico, in Latin America, and I am sure that in many other countries, frequently we treat small children with early childhood caries that in some cases takes them to the loss of several teeth, especially the upper anterior teeth. Some of them with a typical pattern with the lower anterior teeth free of caries, but some other with an atypical pattern where all teeth have to be extracted. As we know, caries in primary dentition can lead to malocclusions and problems for the permanent teeth. We are in times of minimally invasive dentistry. I believe in it, and I try to do it when it is possible. I enjoy doing small restorations on small teeth with no anesthesia and with beautiful results. But today, I'm going to talk about the challenge of restoring severely destroyed teeth with durable and aesthetic restorations. And I'm going to start this presentation sharing with you this clinical case. And this is a 3-year-old kid. This kid was treated under general anesthesia by other dentists who did these terrible and unaesthetic restorations. I'm sorry. As you saw, this is a non-cooperative boy, but after some minutes talking with him and explaining to him the procedure that we would do, we agreed to do just one restoration during that appointment. And I decided to start working on the upper right lateral incisor because the cervical border of that steel crown was hurting his upper lip. So after some local anesthesia administration, I cut the crown to remove it. I did a preparation to place a zirconia crown. And after testing a trying crown, the zirconia crown was cemented with some resin-modified glass ionomer cement. This is a prefabricated zirconia crown. This procedure was done in about 10 minutes, no more than 10 minutes. A week later, they came back. He was happy with his new restoration. He was very cooperative with us, and he was so excited. So, some local anesthesia was administered. With a bore, I cut the crown from vocal to lingual in order to open it and to remove it. Look at this picture. Look at the gum. All that gingival damage was not done by me. It was done by the crown that he had. This is the preparation that I did. I did a preparation convergent to incisal. The incisal angles are rounded, and the finish line was placed 1 millimeter subgingivally. Finally, both central incisors were restored with zirconia crowns, and the left lateral incisor was restored with some composite. Look at this X-ray, and this is important. No pulporotomy or pulpectomy was done. Please look at the position of that crown. Look at the red line. After a week, the gingival tissue follows the new crown. So the crown of the right lateral incisor was placed on the first visit, and the central incisors and the left lateral incisor were restored on the second visit. This is 3 years post-op. Look at the X-ray. As I told you, no pulporotomy or pulpectomy was done. Look at the gum. Look at the crowns. They look beautiful. They look as new. So this is 3 years post-op. Frequently, we treat small children with severely destroyed anterior teeth, whose parents ask or demand highly aesthetic restorations. Stainless steel crowns have been used for more than 70 years, and we are still using them with clinical success. This is important. With clinical success, we love steel crowns, but it is a fact that most of our patients' parents don't like them, especially for the upper anterior teeth. In pediatric dentistry, this is one of the most important evolutions that we had. The transition from the stainless steel crowns to the pediatric zirconia crowns. And look what beautiful restorations we have now. And of course, this kind of restorations should be used in cases with a real indication for placing crowns. A highly polished restoration is more aesthetic. A highly polished restoration causes less wear to the opposite teeth. A highly polished restoration leads to less biofilm buildup, so it's easier to clean. Look at this picture. The upper central incisors are zirconia crowns. The upper right lateral incisor is enamel. The upper left lateral incisor is a composite restoration. Biofilm accumulation on the lateral incisors, no plaque accumulation on the central incisors. The crowns look clean. Let's have a closer look. The crowns look clean. Look at the lateral incisors and look at the central incisors. Let's have a closer look. Look at the crowns. Look at the gum. The gingival tissue around the zirconia crowns looks healthy. That is because one of the most important advantages of the zirconia is to be biocompatible. And talking about biocompatibility, I would like to share with you this case. And this is a 20-month-old little boy. This kid was treated under general anesthesia, and I placed 2 zirconia crowns on the central incisors and 2 pre-veneered stainless steel crowns on the lateral incisors. This photo is after a week. Look at the gum. And this other photo is after 3 months. And this photo is very important for me because it shows the difference in healing process comparing stainless steel crowns on the lateral incisors versus zirconia crowns on the central incisors. The gingival tissue around the zirconia crowns looks healthy, but the gum around the lateral incisors after 3 months still shows some inflammation. 4 months later, this kid fell down, and his right central and lateral incisors were avulsed. He came back to my clinic 3 years later, and he did it because he had caries on an upper first primary molar. And I took a lot of photos. And the first thing that came to my mind when I saw this photo was biocompatible and no biocompatible. Look at the gum around the stainless steel crown. This last photo is 5 years post-op. This clinical case is published in the first book about pediatric zirconia crowns in the world. This book was written by Dr. Song-Ki Kim from South Korea. And Dr. Kim is who developed pediatric zirconia crowns. And that is a great honor for me. Let's compare these 2 kinds of restoration, stainless steel crowns versus pediatric zirconia crowns. Stainless steel crowns are non-biocompatible and non-static. Pediatric zirconia crowns are biocompatible and static. Stainless steel crowns, good clinical performance, proven for more than 70 years. zirconia crowns, good clinical performance, proven for 8, maybe 9 years. No special cement is required to place a steel crown, while resin-modified glass ionomer cements or resin cements are strongly recommended to place a zirconia crown. Less tooth reduction is needed to place a steel crown. Of course, we know that. That is why currently we are teaching a way to do the preparation using some depth cuts done with specific bores with specific measures. I will try to summarize the preparation to place a zirconia crown with this picture. Please just imagine this is a severely destroyed upper central incisor. So the first step is the incisal reduction. We will do about 1.5 to 2 millimeters of incisal reduction. Then we will do mesial, distal, vocal, and lingual reductions. The preparation should be convergent to incisal. So we need to do more reduction here and less reduction here. The incisal angles should be rounded and the finish line must be extended subgingivally in order to have gingival health. Of course, a more aesthetic result, more retention area, and to avoid the cervical border of the crown to be exposed. The next step is the test of a trying crown, and the last step is the cementation of the crown with some resin-modified glass ionomer cement. This is after a week. Look at the gum. And some years later, after the exfoliation of that tooth, this is the cervical adaptation that we could get if we do a correct preparation and, of course, a correct crown selection. This is another clinical case. A 3-year-old boy with an upper central incisor with a vertical fracture. He visited me because he had a small abscess in the apical area of the right central incisor. He was taking some antibiotics from more than a week. So after some local anesthesia administration, I took an X-ray, and after placing a rubber dam, I did a pulpectomy on the right central incisor, and I did a pulpotomy on the left central incisor. For this case, the pulpotomy was done with some Vidapex, while the pulpectomy was done with some neopuri. And neopuri is a premixed MTA by NewSmile. I did preparations for placing crowns. As you can see, the preparations are convergent to incisal, and the finish line of those preparations were placed subgingivally. After testing trying crowns, a couple of zirconia crowns were cemented. At this moment, I would like to talk about the position of the crowns. For a better aesthetical result, the position of the crowns should match with the root alignment. Look at the crown of the right central incisor. It is in a correct position. But look at the crown of the left central incisor. It shows some inclination to distal. The crowns look good, but let me show you what we can do to improve the aesthetic appearance of this kind of restoration after the crowns are cemented. After some days, after the cemented was completely set, I took a finishing diamond bore and I did some reduction at the incisal border of the crown of the left central incisor. It was some days before Christmas. As I told you, this is a very cooperative patient. He was happy with his new crowns. This is 3 months later. In this picture, we can see the part where I did the reduction at the incisal angle, at the incisal border. This is 9 months post-op, and this is before and after a year. Look at the crowns, look at the pulpectomy, and look at the pulpotomy. Another clinical case. This is a very interesting clinical case. A 3-year-old girl. This was a cooperative girl, but just for some minutes, maybe 5, maybe 7 minutes, and it was all. So she visited me because she had caries, and as you can see in this photo, she had a composite restoration on the left central incisor placed by other dentists. These patient's parents didn't want me to treat her under sedation or general anesthesia. So I proposed to them to treating this kid in 3, maybe 4 very short visits to restore the upper anterior teeth, just the upper anterior teeth. By the way, those teeth were completely asymptomatic. Let me show you what I did. First visit, after some local anesthesia administration, I did pulpotomies on the right central and lateral incisors. After controlling the pulpal bleeding, a wet cotton pellet, moist with some sodium hypochlorite, was placed inside the pulp chamber for about a minute, maybe more than a minute. After removing those cotton pellets, the pulp chambers were rinsed with some saline solution. MTA, in this case, Neo-MTA by New Smile, was mixed according to the manufacturer recommendations. And MTA was placed inside the pulp chamber. MTA was slightly condensed with a moist cotton pellet and then was covered with some resin-modified glass ionomer cement in order to protect it during the setting time of the cement. On the second visit, on the next visit, I did exactly the same procedure on the left central and lateral incisors. A week later, they came back with a low-speed round bore. I removed some of the MTA that I had placed in order to have more retention area and more etching area. And after etching those teeth, avoiding etching MTA. MTA shouldn't be etched. Those teeth were built up with some composite. I did preparations for placing zirconia crowns, and 4 zirconia crowns were cemented, in this case with some resin cement. So this is the tooth, this is the pulp, MTA, and the crown cemented with some resin cement. And the question is, how did I get retention? Number 1, by etching those teeth and building up those teeth with some composite. Number 2, placing the crowns subgingivally. And number 3, with a correct cervical adjustment of the crowns. So this is before and after This procedure was done in 3 very short visits. 30 months later, they came back, and they did it because she had an abscess, as you can see in this picture, in the lower right first primary molar. That tooth was extracted. I took some x-rays. Look at the x-rays. Look at the photo. Look at the crowns. As you can see, the second primary molar was restored. I placed a steel crown on the first primary molar. The other first primary molar was extracted. The primary canines were restored with some glass ionomer cement, and of course, a couple of space maintainer appliances were cemented. 36 months post-op. From my point of view, pediatric zirconia crowns are the most aesthetic, resistant, and durable restorations available for this kind of treatment. This is 4 years post-op. The upper left central incisor is erupting. The upper right primary central incisor will exfoliate soon. Look at the crowns, look at the gum. And the question is this minimal invasive dentistry? Is it possible to do minimal invasive dentistry using zirconia crowns? What do you think? Well, I think that restoring severely destroyed teeth on a non-cooperative 3-year-old girl, preserving radicular pulpal vitality with durable and aesthetic restorations, it is minimally invasive dentistry too. This clinical case is published in the Journal of the Mexican Academy of Pediatric Dentistry in 2020. This clinical case is published in this book. This book will be launched in Brazil this year. And I am one of the authors of this chapter, the chapter about zirconia crowns in pediatric dentistry. And this case is published in this book too. And some photos of this clinical case are published in this article about bioactive dental materials. And this article was written by Dr. Caroline Primus. And Dr. Primus is who developed Neo-MTA and Neo-Puri by NewSmile. And now I would like to talk about some special applications in pediatric zirconia crowns. This clinical case that I will show you was presented in a Congress of the IAPD in Chile in 2017 in a lecture called Special Applications in Pediatric Zirconia Crowns. This is an 8-year-old girl. Please focus in her face. Look at her face. Her mandible shows some deviation to the left side. Look at the midline. And the cause of the problem is an upper primary canine in a crossed bite position. When she bites, the upper primary canine is pushing the mandible to the left side. Look at this video. Look at the midline. And we can notice that mandible deviation facially, dentally, and even in this X-ray. As dentists, as orthodontists, as pediatric dentists, we know the importance of correcting this malocclusion as soon as possible before she develops a real skeletal problem, a real skeletal deviation. How could we solve this problem? We could place a Hyrax expander cemented on the upper arch. Maybe we could use an acrylic inclined plane bonded on the lower arch. Or maybe we could use a Holy appliance with a finger spring or a screw or something to push that upper canine. Maybe we could solve this problem with a quad helix expander. The most interesting part of this clinical case is that this malocclusion, this problem was solved using just one prefabricated zirconia crown. And will be my pleasure to show you step by step how I did it. I will use this typodont to show you the adjustments that I did at the lingual surface of a zirconia crown to place this crown in an inverted position. As you can see, this red arrow shows an inclined plane formed by the vocal surface of a crown when it is placed in an inverted position. With a diamond board, with a finishing diamond board, and using a lot of water, I did some reduction at the lingual surface of a zirconia crown. That reduction was done with a soft touch of the board, with a lot of water. That's important. Zirconia can be reduced by using a lot of water. I am testing the crown in an inverted position, and the crown was cemented with some resin-modified glass ionomer cement. It is very important for me to say that no local anesthesia was administered for this procedure. No tooth preparation was done on the upper primary canine. No teeth reduction was done on any tooth of the mouth. For this case, I am using a crown of a central incisor because I wanted a big inclined plane, a big area to work with. Now, the vocal surface of the crown of a central incisor will act as an inclined plane. The use of a crown in an inverted position to correct a single tooth in a crossbite position is a well-known method for us as dentists to correct the malocclusion. When you cement a crown with the lingual side facing vocal, the forces of the occlusion will push out the upper tooth, correcting the crossbite. That red line, that green line was placed there to show you the adjustments, the reductions that I did at the lingual side of that crown to permit an inclined position of the crown. Now, the vocal surface of that crown will push the mandible to the correct side. Look at the midline 2 months later. The crossbite is corrected, and the midline was corrected. This is 2 months later. 3 months later, the crown looks clean. The gingival tissue around the crown looks healthy. 3 months later, look at the midline. And I think that after 3 months, it is time to remove the crown. No local anesthesia was administered to do this procedure. I just cut the crown from buccal to lingual with a finishing diamond bore with a lot of water, and the crown was removed. The enamel was clean, was polished, and I took an X-ray. Look at the midline. No orthodontic retainer was placed in this case. I just wait for the occlusion to settle. 6 months later, look at the occlusion. The molars are in a class 1 occlusion, and look at the occlusion of the canine. A year later, we can see the first permanent molar is in a class 1 occlusion. Look at the midline after a year. 2 years later, look at the midline. 3 years later, look at the midline and look at the occlusion of the permanent canine. It is in a class 1 occlusion. So, my personal conclusion for this clinical case is the use of a zirconia crown to correct the malocclusion, the crossbite of a single tooth, seems to be a good idea. This treatment option is inexpensive, efficient, requires no non-special cooperation from the kid, avoiding the silver appearance of the use of a stainless steel crown for the same purpose. This clinical case was presented for the first time in a congress of the Korean Academy of Pediatric Dentistry in 2016. This clinical case is published in the Journal of the Mexican Academy of Pediatric Dentistry. This clinical case is published in this book in Germany, and this is a great honor for me. And now I would like to talk about the clinical application of aesthetic crowns in trauma cases. And this is an 18-month-old little girl. She visited me because she had a complicated crown root fracture. As you can see, the pulp was exposed. I took an X-ray. The apex is completely open. So the restorative alternatives, the treatment options to save that tooth were so limited. Look at the position of the broken tooth. It is rotated, and the mesiodistal available space to restore this tooth was reduced. And honestly, in a case of this, like this, I wouldn't want to place a crown, a zirconia crown, in a rotated position. Let me show you what I did. I did a pulpotomy. Again, I did a pulpotomy using neopuri by NewSmile. Neopuri was covered with some resin-modified glass ionomer cement to protect neopuri during the setting time, and of course, to start the preparation, the reductions needed to restore that tooth during the same appointment. Look at the position of the broken tooth. It is in a rotated position. Let me show you what I did. This is the preparation that I did. I did a preparation convergent to incisal. The incisal angles are rounded, and the finish line was extended subgingivally. Finally, a crown of a lateral incisor was used to restore that central incisor. So I placed a crown of a lateral incisor because the lateral incisor is smaller than the central incisor. The crown looks smaller than the other central incisor, but the rotation was corrected. So this is the result. This is before and after. Another clinical case of a broken tooth. This is an 18-month-old boy. He had a car accident. Both central incisors had, crown root fractures with the pulp exposed. This kid was treated under general anesthesia. While I am treating her broken teeth, his father, that is a doctor, was suturing a cut in his face. That is the reason why he was treated under general anesthesia. I'm sorry. So I did pulpotomies on both upper central incisors. That is neo-MTA. Look at the preparations that I did. Look how the crown root fractures, look how long the crown root fractures were into subgingivally. I mean subgingivally. After testing a couple of pre-veneered stainless steel crowns, in this case, the crowns were cemented with some resin-modified glass ionomer cement. Why did I place stainless steel crowns for this case instead of placing zirconia crowns? The reason is because with stainless steel crowns, I can leave the lingual side of the crowns as long as needed to cover the fracture area of those teeth. Look at the crowns. They were placed subgingivally, at least at the lingual side of those teeth. So this is before and after. Look at the pulpotomies. After a week, a lingual view after a week, a vocal view after a month, before and after, before and after almost 2 years, 20 months post-op. Look at the pulpotomies. Look at the dentinal bridge formed here, which means that the pulp of those teeth are alive. So this is 20 months post-op. Another clinical case, a very interesting case. I'm sorry, give me a second. This is an 8-month-old little boy. Look at this photo. And the pulp of that tooth is exposed by more than 2 weeks. Look at this photo. Look at the X-ray. Look at the apex of that tooth. The restorative options were so limited. Doing a pulpectomy in that tooth was impossible. Maybe an extraction would be okay for this case. And honestly, I really wanted to save that tooth. Let me show you what I did. After some local anesthesia administration, this is the first visit, I did a pulpotomy on that upper central incisor. That is neo-MTA. Neo-MTA was placed after controlling the pulpal bleeding. Neo-MTA was used to fill the pulp chamber, and neo-MTA was covered with some resin-modified glass ionomer cement in order to protect it during the setting time. That was all for the first visit, a 5-minute visit. After a week, 2 weeks, they came back. I did a preparation to place a zirconia crown. And after testing a trying crown, this is the trying crown. The trying crown is a pink crown, a zirconia crown with a pink shape. And that crown is used for testing purposes. Finally, a zirconia crown was cemented with some resin-modified glass ionomer cement. As I told you, this is an 8-month-old little boy. 4 weeks later, look at the red arrow. Look at the dentinal bridge that is being formed, which means that the pulp is alive after just 4 weeks. And this is amazing. 14 months post-op. Look at the dentinal bridge form. Look at the roots of these teeth and the lateral incisors are erupting. Advantages to keep the pulp alive. Number 1, we will get thicker radicular walls. Number 2, we will give more time to the bone for maturation. Number 3, we will get better crown root proportions. And number 4, we will allow the apex to close. This clinical case won the Anna Fuchs Award in Pediatric Dentistry in 2018. But what makes this clinical case so interesting? Of course, the first reason is because of the age of the child and the way it was treated. I did a pulpotomy, the tooth was restored with a zirconia crown, under local anesthesia, with his mother singing to him, helping me to hold the kid while I was working. It was just a baby. But to understand what makes this case so interesting, I would like to show you some pictures. And this is a 13-month-old little boy with an identical clinical situation. This clinical case was treated in Spain by Dr. Camila Palma. This is another case with a very similar situation, and he was treated by Dr. Flavia La Roca in Peru. Similar age, different countries, no history of trauma, no history of pain, no history of complications during birth, no history of illness or fever or hospitalization during the first 6 months of life. And that is very important. And here we can see the treatment done on each affected tooth. Three different patients with 3 identical clinical situations. And we think that we are facing 3 identical clinical cases from 3 different countries. And we believe these cases are a developmental defect called preeruptive intracoronal resorption. All of us know cases of this entity on permanent teeth and on posterior primary teeth. And we can find them published in journals. But to our knowledge, there are no published cases of preeruptive intracoronal resorption on anterior primary teeth. So this could be the first reported cases of this entity reported in the world. These clinical cases are published in the Journal of the American Academy of Pediatric Dentistry on March-April 2020. When we talk about developmental defects of enamel, we can find any tooth affected. At this time, I'm going to start talking about defects of enamel. And I will focus this second part of this presentation in one of the most frequently found in our daily practice. I will focus the second part of this presentation in molar incisor hypomineralization and the different treatment options to restore the hypomineralized anterior teeth and hypomineralized first permanent molars. I think we need to do a break at this time, maybe a 3-5 minute break, if you agree.
Yes, Doc. We can take a 3-minute break, so we will resume at 5:54. That is okay. Casián? I just wanted to ask, do you want us to take questions for the first session, or you want us to do the questions at the end?
I'm sorry, maybe at the end is okay. It's up to you.
It's okay. Maybe I think we can, I didn't see many questions on the chat group. So maybe at the end then. If colleagues, if anyone has a question, just post them on the chat box, then we can look at them at the end of the presentation.
Do you want me to continue? I'm sorry.
Yes, Doc, you can continue.
Okay.
Okay. Please,
Perfect.
please carry on. It's important to us.
Okay, I'm going to continue. Now I'm going to talk about some developmental defects of enamel. And I will focus this second part of my presentation in one of the most frequently found in our daily practice. So I will focus this second part of the presentation in the topic of MIH. The term MIH was introduced for the first time in 2001 with a prevalence from 2 to 40%, depending on the research. And currently, we see a lot of MIH cases in our daily practice. 1 in 6 children are a lot of cases. This was published in 2017, and they found no difference comparing boys and girls. And the highest worldwide incidence was before 10 years of age. On this study, they found no difference comparing upper and lower molars. But some other studies have found that the most frequently affected first permanent molar is the lower right first permanent molar, then the lower left first permanent molars, and then the upper molars, in that order. When we talk about enamel defects, we can find any tooth affected, one side or two sides, asymmetrically or symmetrically. And of course, we can find hypomineralized primary teeth. Look at this primary canine associated to second primary molars. Same patient. Another kid with a hypomineralized lower second primary molar. By the way, the second primary molar is the most frequently affected primary tooth. Look at this primary canine. Look at the buccal surface of this primary canine. And look at the broken enamel at the distal cusp of this primary canine associated to a hypomineralized lower second primary molar. And the question is there a predictive relation between hypomineralized second primary molars and molar incisor hypomineralization? The answer is yes. Hypomineralized primary molars are predictor of molar incisor hypomineralization. Look at this second primary molar, a hypomineralized second primary molar associated to a hypomineralized lower first permanent molar that is erupting. Look at this primary canine associated to a lower central incisor, a permanent tooth. I love this book, a beautiful book, edited by Catherine Bakes. And I really love the title of this chapter. MIH, more questions than answers. We are facing a situation that we don't really know what is causing it. Of course, we have some hypotheses, but we are not sure about the real cause. It is hard for parents and for patients to understand what is happening. It is our fault, say parents. Of course, no, say doctor. Is it something that the kid did when he was a little boy, when he was a baby? No, say doctor. It is just a bit of bad luck. A bit of bad luck. So, this is Isabella Casián. This is my daughter with a bit of bad luck. Look at her upper incisors. Look at this hypomineralized area at the incisal edge of this lateral incisor. Look at this central incisor and look at this lateral incisor. And these are her upper and lower first permanent molars, right side, just the right side. And in this photo, we can clearly notice an atypical composite restoration at the tip of that cusp. That composite restoration was replaced at least 2 times during the last year. Look at this X-ray. This is very interesting. This is a 6-year-old kid. As you can notice in this X-ray, he has a couple of supernumerary teeth, a couple of mesiodents. I took this X-ray in 2018. They came back a year later, 2019. The supernumerary teeth were extracted and MIH was detected. Some recommendations were given to his parents about brushing, about fluoride applications, about MIH paste, etc. They came back almost 2 years later. Look at X-ray. Look at this upper first permanent molar. Look at this lower first permanent molar. And look at this upper first permanent molar. So we must understand MIH as a dynamic process. And that is related to enamel breakdown. Enamel breakdown occurs when the occlusion is under load of occlusion forces. And enamel breakdown do not happen on anterior teeth, but it could happen on canines and upper central incisors. And this is very important. What is and what is not MIH? Following the definition of MIH, it affects first permanent molar, sometimes related to anterior teeth. But at least one first permanent molar has to be affected to be called molar incisor hypomineralization, following the definition of MIH. So these are hypomineralized upper and lower second permanent molar. How could we call this? Just hypomineralized second permanent molars? I am not sure about the way we could call this. Maybe it is time to update the definition of molar incisor hypomineralization, a new definition that includes hypomineralized second permanent molars or any other tooth. This is, of course, MIH. We can call this MIH because it includes a hypomineralized lateral incisor, a hypomineralized canine, and a couple of first permanent molars are affected. So we can call this molar incisor hypomineralization, according to the definition. We need to take actions. We need to identify who has it. We need to educate parents and patients about control of biofilm. We can fortify enamel in some cases with fluoride varnishes, with MI paste, in some cases doing enamel infiltration, enamel microabrasion and infiltration of enamel. We will talk about that topic later. And we need to control teeth sensitivity, because teeth sensitivity makes children to avoid brushing, and that will cause caries. We need to act as soon as it is detected. And of course, we need to understand, we need to know the difference between a hypoplasia and a hypomineralization. During the development of enamel, there are two big stages: the secretory stage of enamel and the maduration stage of enamel. If something wrong, if an event occurs during the secretory stage of enamel, the enamel could be hypoplastic. It is a quantitative defect of enamel, but if something wrong occurs during the maduration stage of enamel, the enamel could be hypomineralized. It is a qualitative defect of enamel. So this central incisor is hypoplastic. The borders of the defect look rounded and the enamel looks hard without caries, free of caries. It is a quantitative defect, and this is a hypomineralized central incisor. It is a qualitative defect of enamel. The enamel looks porous and breaks very easy. The left side is a hypoplastic molar, while the right side is a hypomineralized molar. And this is a beautiful design, a flower design. These lateral incisors are hypoplastic. Look at the borders of the defect. They look rounded and free of caries. Both sides, upper and lower, same patient. And the lateral incisor is hypomineralized. It's a qualitative defect. And I can see a lot of risk factors in this picture. I see a hypomineralized lateral incisor, food, plaque accumulation, gingival inflammation, a lot of risk factors for those teeth. A lot of risk factors for these teeth. Let's have a closer look. I can see hypomineralized enamel. Brackets are, of course, a risk factor. Excess of cement of those brackets. Plaque, gingival inflammation. A lot of risk factors for this hypomineralized anterior teeth. Look at this girl. This is an 11-year-old girl. She visited a dentist because she had a severely destroyed primary molar. She was happy. She was so cooperative. She was smiling until she knew it was a permanent molar. And due to the age of 11, her parents thought it was a primary molar and they were waiting for the exfoliation of that tooth. That is the reason why they didn't visit a dentist. That first permanent molar has had to be extracted. This is very interesting. By the age of 9, children with MIH needed to visit a dentist 10 times more frequently than the control group, and each affected tooth needed to be treated at least 2 times. On this study, they found that 47% of composite restorations needed to be replaced after 34 months. It's not too bad. It is almost 3 years. Maybe it is okay for a hypomineralized tooth. While 63% of glass ionomer cement restorations needed to be replaced after 18 months, which demonstrate an erratic clinical performance of glass ionomer cement restorations on a medium term. Both kinds of restoration needed to be replaced, which can take children to extensive and atypical restorations too early. Look at this crown on a teenager. An atypical restoration on a teenager. Any kind of restoration has a limited life. Even stainless steel crown can fail, especially if they were placed too early. Problems that we face at restoring. Number 1, problems to have enough anesthesia to do the restoration, the preparation. Hypomineralized enamel is not good isolating the pulp. That is the reason why those teeth have sensitivity. Behavior problems. If there is pain, the patient will not cooperate with us. Adhesive issues. Restorations that need to be replaced frequently. Parents and patients complaining about the cost of the treatment because they are very expensive treatments in some cases. And I will add another point, that is aesthetic requirements or demands from the patient or the parents of the patient. Let's talk about restorative procedures. As pediatric dentists, we treat kids with enamel defects in primary dentition, for example, this case, hypomineralized and broken down second primary molars, both sides, upper and lower. We can treat this kind of cases with stainless steel crowns, with or without pulporomies. And of course, we can treat this kind of cases using zirconia crowns. Both kinds of restoration with excellent clinical results. This is after a year. After a couple of years, the first permanent molars are erupting, as you can see. After 3 years, after more than 4 years, occluding pediatric zirconia crowns against stainless steel crowns, with no problems and with no signs of excessive wear on the stainless steel crowns, occluding against zirconia crowns for more than 4 years. But what about permanent dentition? This is a hypomineralized lower first permanent molar on a teenager, and that is the pulp. The pulp is exposed. Is the pulp lophinatose? I think it is. Let's talk about restorative procedures for hypomineralized permanent molars. Amalgam restorations are not an option and shouldn't be used to restore hypomineralized permanent molars. So I will not talk about amalgam restorations. For many years, we have been treating enamel defects on permanent teeth, on posterior permanent teeth, with number one, composite restorations, with very good clinical results if the margins of the preparation and, of course, their restoration were extended a bit into hard and not porous enamel, and if the restoration was placed on the rubber dam isolation. So the key is rubber dam isolation to control humidity and extending a bit the margins of the restoration into hard enamel. Number two, with glass ionomer cement restorations. With good clinical performance, but an erratic clinical performance on a medium term. Even with that, after a year, after a couple of years, we can see these glass ionomer cement restorations placed by me a couple of years before, maybe. We can just repair these restorations without removing the glass ionomer cement, and there is no caries, so there is no reason to remove all the glass ionomer cement. But glass ionomer cement restoration shows an erratic clinical performance on a medium term. The next option is the combination of an orthodontic band cemented and filled up with some glass ionomer cement. This is a very interesting way to restore a hypomineralized molar. This should be considered as a temporary restoration, as a therapeutic restoration to control teeth sensitivity, for example. And this kind of restorations works very well as a temporary restoration. And they can be placed with no anesthesia. Look at this second primary molar, a hypomineralized second primary molar, and associated with a hypomineralized upper first permanent molar. It was treated cementing an orthodontic band, and the band was filled up with some glass ionomer cement. As I told you, this should be considered as a therapeutic restoration. Next treatment option are stainless steel crown. As I told you, we love steel crowns. They work very well for hypomineralized teeth. We can control sensitivity immediately after placing a steel crown for those cases that needed full coverage. And of course, with a combination of different dental materials, and different restorative procedures. We can see here the tooth was built up with some glass ionomer cement. After doing the preparation, a stainless steel crown was placed. We can see in this X-ray that root canal treatment was done. And I am performing an orthodontic treatment. Another clinical case, treated with a stainless steel crown, a lower first permanent molar, a hypomineralized tooth. After placing a rubber dam, the tooth was built up with glass ionomer cement. I did the preparation to place a steel crown, and a new smile steel crown was cemented. Another example, look at this hypomineralized lower first permanent molar. As you can see, that tooth has an old and broken amalgam restoration. As I told you, amalgam restorations are contraindicated for hypomineralized teeth. So both teeth were restored with steel crowns. The crown of the second primary molar was changed, was replaced, and I did a pulpotomy on that lower first permanent molar. Next treatment option for hypomineralized permanent molars are whole technique stainless steel crowns. Look at this upper first permanent molar, a hypomineralized tooth with a lot of sensitivity. Without anesthesia, I just placed an orthodontic separator for a couple of days. And after a couple of days, the orthodontic separator was removed. I am testing a zirconia crown, stainless steel crown, on that tooth, and the stainless steel crown is cemented with some glass ionomer cement, with no preparation, with no local anesthesia. Whole technique on hypomineralized permanent molars. Next treatment option are prefabricated zirconia crowns. For those cases that needed full coverage, same as stainless steel crowns, but for those cases that the patient demand an aesthetic restoration with this kind of restoration will last for a lot of years. All of us know the advantages of using a pre-made restoration of on a kid. No lab work is needed. No impression is needed. The restoration is placed in just one visit, low cost, and even in partially erupted molars, we can place this kind of restoration because we don't need to take an impression to place it. The next treatment option are the extractions of the hypomineralized permanent molars. Look at this patient with hypomineralized permanent molars, both sides, upper and lowers. And now I would like to share with you this clinical case. Let's talk about what MIH is. Regarding the clinical appearance of MIH, the molars and the incisors can have demarcated opacities, of course, in different degree on different teeth. Enamel breakdown is an important part of MIH, especially in molars, but we can also see it on incisors. We can also see enamel breakdown on anterior teeth. We don't expect to see a 9-year-old child, a girl in this case, with an upper first permanent molar like this, a broken down molar with a lot of sensitivity, with a lot of plaque and caries associated to MIH. Look at this patient. In this picture, we can notice the asymmetrical presentation of MIH. A lower first permanent molar affected with caries associated to hypomineralized enamel, a broken down upper first permanent molar with a lot of sensitivity, And as you can notice, an upper second premolar is affected too. And of course, the upper and lower anterior teeth. Hypersensitivity is an important part of MIH. In some cases, even in teeth with no enamel breakdown. I would like you to focus on this tooth, tooth number 26, upper left first permanent molar. We see loss of hard tissues, an upper molar with a lot of sensitivity. She had pain. She couldn't eat with that side of her mouth. Look at the X-ray. When we think about treatment options, an important factor is the age of the patient. Please take this in consideration when you think about treatment options. It is not the same if we talk about a 7-year-old kid or maybe a 10-year-old kid. In terms of compliance, in terms of cooperation, of behavior during the treatment. Let's think about treatment options. What are your treatment alternatives for this case? Maybe partial caries removal and a glass ionomer cement restoration. That could be an option. Whole technique stainless steel crown. Maybe some of you could be thinking about a viral pulpotomy, restoring with a stainless steel crown. Some of you could be thinking about doing a root canal treatment, restoring with a prefabricated zirconia crown. Maybe that could be a good option. And the extraction of this tooth could be the last option. Let me show you what I did. After some local anesthesia administration, I placed a rubber dam. The use of rubber dam isolation is very important in this kind of treatment. In fact, my personal recommendation is single tooth isolation with the purpose of avoiding contact with other affected teeth with the water or spray produced during the restorative procedure. So, after placing a rubber dam with a low-speed round bore, I removed this soft dentin, of course, trying to avoid the pulpal exposure. That was impossible. So I decided to do a pulpotomy. After controlling the pulpal bleeding, a wet cotton pellet moist with some sodium hypochlorite was placed inside the pulp chamber for about a minute in order to disinfect the pulp chamber. After that, new MTA was mixed according to the manufacturer recommendation. That is very important. And it was placed inside the pulp chamber. MTA was slightly condensed with a moist cotton pellet. And then MTA was covered with some resin modified glass ionomer cement in order to protect it during the setting time of the cement and in order to start the preparation to place a restoration during the same appointment. About the preparation to restore the tooth, I just did some occlusal reduction in that part of the occlusal surface. I did about 1 millimeter of occlusal reduction. I didn't do mesial or vocal reductions. I don't even touch the vocal and lingual surface of that tooth. After testing stainless steel crown, the crown was cut, was contoured, and of course one was polished. The crown was filled up with some resin modified glass ionomer cement, and it was cemented. In this kind of cases, it is very important to take an X-ray to be sure that the second permanent molar is not being trapped by the crown that you are placing. As you can see, the root of the second primary molar was extracted. Look at the cervical adaptation of this crown in this X-ray. This is very important. After a week, the patient came back, the tooth sensitivity had disappeared. Now she was able to brush her teeth. She was able to eat in a normal way. And now it is time to start working on the lower right first permanent molar. Look at this tooth. Look at this hypomineralized area and caries associated to the hypomineralization. Look at the X-ray. So after local anesthesia administration, I placed a rubber dam and I decided to do a partial pulpotomy, a Sbeck partial pulpotomy. So after controlling the pulpal bleeding, the pulp was covered, was protected with some MTA. Again, in this case, I am using Neopuri. As I told you, Neopuri is a premixed MTA by NuSmile. This is Neopuri. Neopuri was covered with a drop of Jonosil. Jonosil is a mix of resin cement with glass ionomer cement. It was used just to cover MTA and to protect it during the setting time. That tooth was etched and was restored with some composite. The root of the second primary molar was extracted at this time. Look at the partial pulpotomy. After a week, again, the sensitivity had disappeared completely. The upper molar and the lower molar after 3 weeks. This is the third visit. Now it is time to start working on the upper second bicuspid. After placing a rubber dam with a big low-speed round bore, I tried to remove the affected dentin. No pulpal communication was done. Even with that, the pulp was protected with some Neopuri, with some MTA, and the tooth was restored with some composite. 6 months later, this kid came back. She was happy because she was able to eat, to brush her teeth. Look at the crown with some gingival inflammation around the crown, especially at the lingual side of that crown. Look at the cervical adaptation of the crown. And as you can see, the second permanent molar is erupting at this time. Before and after 6 months. The lower molar after 16 months, preserving pulpal vitality. The upper second bicuspid after 16 months. And look at these X-rays. This is before and after. As you can notice in this X-ray, the second permanent molars are erupting. Before and after 16 months. And this is very interesting. Note the position of the second bicuspid. After some months, that tooth is settled into position, into a correct position by itself. The second bicuspid is moving into a correct position. It is too easy to talk about and to show the occlusion of a restoration placed by us from a lingual view, from a vocal view, because we can take a photo from vocal, but it is not possible to see how a restoration is working from a lingual view. But currently, with new technology, we can scan the mouth and we are able to see, to take a look of any restoration that we are placing from a lingual view. So now we can see how the restoration is working from a vocal and lingual aspect. And we are able to see how it's occluding. So in these photos, we can notice that the occlusion was not altered after the placement of the stainless steel crown. 18 months later, look at the crown and look at the second permanent molar erupting. One of my favorite treatment options, if we have a lot of enamel breakdown, are prefabricated stainless steel crowns, especially if a pulpotomy was done. They work perfect for hypomineralized molars. They have a very good survival rate, and they maintain occlusion and reduce hypersensitivity immediately. The preparation to place a stainless steel crown is too easy and can be placed, the crowns can be placed in about 10 minutes, maybe less than 10 minutes. I love this clinical case because it shows 3 different treatment options for 3 different teeth from 3 different quadrants, of course, in the same patient. And these 3 treatment options were done preserving pulpal vitality. This is a very interesting article to read, and they found that success rates in pulpotomies are more than 21%, as well as partial pulpotomies success rates, over 21% of clinical success. So this is a very interesting article to read. Another clinical case, a 10-year-old girl with MIH, look at her lower anterior teeth, and she visited me with a severely destroyed, a broken down lower first permanent molar. She said that she had a metallic restoration, a silver restoration on that tooth. Maybe a stainless steel crown, maybe a band with some glass ionomer cement. I really don't know. She visited me with a lot of sensitivity. Look at the X-ray. So after some partial caries removal, of course, after local anesthesia administration, and even when no pulpal communication was done, the pulp was protected with some MTA. Look at the preparation that I did. I did no preparation. I just placed the finish line subgingivally. After controlling the gingival bleeding using viscostat clear, and viscostat clear is aluminum chloride. After testing a trying crown, this is the trying crown, a pink zirconia crown to be used for testing purposes. The white crown, the zirconia crown, was cemented with some resin-modified glass ionomer cement. This procedure was done in about 15 minutes, no more than 15 minutes, in just one appointment. 2 weeks later, look at the gum. 3 months later, the second bicuspid is erupting. 5 months later, of course, I am preserving pulpal vitality and the tooth sensitivity disappeared. 8 months later, as always, zirconia crowns look clean because the highly polished external surface that they have. 2 years later, the second permanent molar is erupting at this time. Look at the crown. As I told you, no pulpotomy or pulpectomy was done. The pulp is vital. So this is before, immediately post-op, and 2 years post-op. I just placed an orthodontic separator here to help the second permanent molar to be free of erupting. And now I would like to talk about what I did on the lower anterior teeth. Due to the position of those lateral incisors and the biofilm, the plaque accumulation on them, those hypomineralized teeth needed to be protected. So after local anesthesia administration, I placed a rubber dam. And after absolute isolation, I did some microabrasion. I did a first round of opalustre by Ultradent. It's 6.6 hydrochloric acid. And then I did the full protocol of DMG icon system. That is the acid application of the hydrochloric acid for 2 minutes. The acid was applied 3 times. After rinsing, after drying, look how the hypomineralized enamel looks like. And this is after the resin infiltration. I will go back, look at this photo, and this is after the resin infiltration of enamel. Before and after the resin infiltration, the enamel is protected now. The rubber dam was removed. In this photo, you can see the zirconia crown that I placed in the lower first permanent molar. As you can see in this photo, these are the primary canines, and the clamps to hold the rubber dam were placed on the lower first primary molars. A year later, the lower permanent canine is erupting now, and this is the primary canine. This first primary molar was exfoliated. Look at the hypomineralized enamel treated with icon system. This enamel was infiltrated a year before. Look at this photo. Look at the smooth surface of those anterior teeth. 2 years later, the permanent canines are erupting. The first bicuspid erupted. Look at before and after 2 years. This is a primary canine and this is a permanent canine. So this is 2 years later. Before and after 2 years. Before and after 2 years. 28 later, after the crown was placed. I am performing an orthodontic treatment, and this is 3 years after the zirconia crown was placed. Look at the second permanent molar and look at the zirconia crown after 2 years. No pulpectomy or pulpectomy was done, and the pulp is alive. This is the new book of Dr. Catherine Bakes. This was published in this year. And this clinical case is published in this book. And that is a great honor for me because this is the first time that a book about MIH talks and consider zirconia, prefabricated zirconia crowns as a restorative alternative for hypomineralized permanent molars. And that's a great honor for me. And in the chapter number 15, the same patient, the treatment done on the anterior teeth is here too. Now I would like to take this chance to invite to all of you for joining us to the Molar Incisor Hypomineralization Forum on Facebook. This is a great place to share clinical cases, to learn, to teach. Every day we share clinical cases, we share articles, we share research. Join us, you will enjoy being part of the Molar Incisor Hypomineralization Forum in Facebook. Join us. About the preparation, we don't have enough time to talk about this topic, but we try to do a preparation as conservative as possible. I invite you for taking some hands-ons and some courses to learn the way we do the preparation, to learn the recommendations of the manufacturer of this kind of prefabricated zirconia crowns, the way we should work on the tooth to avoid over-reduction of those teeth. This is the trying crown. I have talked about the zirconia crowns, about About trying crowns are zirconia crowns with a pink shade, and trying crowns are used for testing purposes to avoid blood or saliva contamination of the zirconia crown, the white crown, to be cemented. About the cementation procedure, and this is important, place the crown with your finger. Hold the crown with your finger, avoid the movements. Polymerize for about 3 seconds at the lingual side of the crown and 3 seconds, at the vocal side of the crown. And after that, you can remove the excess of cement. About the preparation of the tooth. This upper first permanent molar had a broken stainless steel crown. So I will use this photo to talk about the preparation. I did about 1.5 millimeters of occlusal reduction. I did a vocal and lingual cuts, and I did some vocal reduction. The rubber dam was removed, and the finish line was placed 1 millimeter subgingivally. I have been placing in my clinic zirconia crowns for more than 8 years. Anterior and posterior teeth, different brands of zirconia crowns. And I realized that to have a predictable clinical success, there are 3 points to consider. The first one is a correct preparation of the tooth. Preparation that should be done as conservative as possible. The second point is the use of a trying crown to avoid blood or saliva contamination of the crown to be cemented. And the third point is the utilization of an excellent cement. And this last point is very important. After cementing the crown, due to the position of this first primary molar, I decided not restoring the second primary molar at this time. After a week, look at the gum. 2 weeks later, I love this photo. 3 months later, after the exfoliation of this first primary molar, I decided to restore the second primary molar. And a frequent question is it possible to place a clamp to hold a rubber dam on the crown? Yes, of course it is possible. And after restoring that second primary molar, we cannot see marks of scratches on that crown after removing that clamp. 2 years later, 4 months later. Is it possible to do a root canal treatment just in case? After cementing a zirconia crown, yes, it is possible. You can do a hole, you can do a pulpal access with a diamond bore, and you can do a root canal treatment, and then you can fill that hole. This is a beautiful case. I think this is the last one, and I will call it Enamel and Zirconia Mountains. A teenager, and that is a second primary permanent molar. This is her lower first bicuspid, and this is her upper second bicuspid. And she visited me with a lot of sensitivity. She couldn't eat with that mouth, with that side of her mouth. So I placed a rubber dam, and after a couple of big pulpal communications, I decided to do a pulpotomy. After controlling pulpal bleeding, MTA was mixed according to the manufacturer recommendations. MTA was placed inside the pulp chamber, and it was slightly condensed with a moist cotton pellet. After that, MTA was covered with some resin-modified glass ionomer cement. The rubber dam was removed, and I took an X-ray. Look at the preparation. Again, I did no preparation. I just placed the finish line 1 millimeter subgingival. After testing the crown, after checking the occlusion, a zirconia crown was cemented. A lingual view of the crown just placed, an occlusal view of the crown, and the occlusion. A month later, 3 months later. At this time, she was ready to start the orthodontic treatment that she needed. But her parents decided to wait a year. So after 13 months, they came back. I took some photos and, of course, an X-ray. 14 months post-op. And finally, the lower and upper brackets were placed. In this photo, I am correcting the crossbite position of the canine. And this is very interesting. Look at the upper second permanent molar. I took these photos just after the patient entered to my operating room. No rinsing, no washing was done before taking those photos. Look at the upper second permanent molar. It looks completely dirty. Look at the crown. I'm sorry. Look at the crown and the gum around the crown. The crown looks clean and the gum looks healthy. 24 months post-op, 28 months post-op, 40 months post-op, 44 months post-op. The brackets were removed and the crown looks as new. Look at the X-ray. And of course, another treatment option, a good one, I think, would be the extraction of the second permanent molar, waiting for the correct eruption of the third molar. Her parents didn't accept that treatment option, so I had to save that too. Again, a vocal view. And a lingual view of the crown. And as you can see in this photo, we can see the palatal cusp of the upper second molar occluding at the center of the occlusal surface of the Zirconia crown. Another view, the crown occluding against a natural tooth and the occlusion. And after almost 4 years, if we compare the opposite tooth occluding against a Zirconia crown for 44 months, we cannot see marks of excessive wear on a hypomineralized upper second permanent molar occluding against a Zirconia crown, a prefabricated Zirconia crown, for more than 44 months. This clinical case is published in the Journal of the Mexican Academy of Pediatric Dentistry. This clinical case is published in the Journal of Clinical Pediatric Dentistry in this year. And this is published here. And it is a great honor for me that my clinical case is published here. How are we about timing? Do we have time to see the last case, or should we stop now?
Hello, Doc. How much time do you need?
5 minutes.
Yeah, I think we should be able to finish that case and then take a few questions.
Okay, perfect. Perfect. So I really want to show you the clinical case because this is a very interesting case. In fact, this is the first time that I'm going to present it. I am preparing this case for a congress about MIH in Dubai next year. So I would like you to invite about treatment options for this clinical case. A teenager, look at the occlusion, a class 2 malocclusion this side, almost class 3 malocclusion in the other side, and a second bicuspid in the palatal side, out of the dental arch. Look at the X-ray. Of course, this is an MIH case, a hypomineralized upper first permanent molar. Look at the upper and lower anterior teeth. We can see some demarcated opacities here. And look at the X-ray. Look at the occlusion and look where is the second bicuspid. Think about treatment options. A hypomineralized upper first permanent molar with a lot of sensitivity. This patient came to my clinic asking me an orthodontic treatment. She needed an orthodontic treatment. Look at this video, look at the occlusion, look at the second permanent molars where they are. They are in a vocal crossbite occlusion, both sides of the second permanent molars. And look where the second bicuspid is located. So let's think about treatment options. Option number one, of course, this kid needs an orthodontic treatment. That is the reason why she visited me. Option number one, restoring the upper first permanent molar with a stainless steel crown, extracting the second bicuspid. Option number two, direct or indirect composite restoration, extracting the second bicuspid. Option number three, an orthodontic band cemented on that tooth, filled up with some glass ionomer cement, extracting tooth number 15. Option number four, restoring the hypomineralized upper first permanent molar with a prefabricated zirconia crown, extracting tooth number 15. Think about treatment options. Which one is the good one for you? Maybe all treatment options could work for this tooth. But I have another treatment option for this case. What about extracting tooth number 16? What about extracting the hypomineralized first permanent molar? That tooth was extracted. Look at these photos. The vocal face, the mesial face. Look at this tooth. An orthodontic treatment was started. I am pulling the second bicuspid, a healthy tooth. I am trying to rotate the tooth, and I am taking the second bicuspid into correct position. I will move the upper first permanent molar into the position of the upper first permanent molar. Before and after 6 months. And now I am waiting the third permanent molar to erupt in the position of the second permanent molar. A very nice case. Look at the root of the second bicuspid. It was not affected by the orthodontic treatment. And look at the second permanent molar. The second permanent molar is being placed in the position of the extracted upper first permanent molar. A very easy way to solve a very complicated problem. With a very easy orthodontic treatment, I am moving the second bicuspid after extracting the upper first permanent molar. Well, I think I will finish my presentation here. I'm sorry. If you have any question, feel free of asking me. If you need further information about this topic, please send me an email and it will be my pleasure. I will go forward. I'm sorry. If you have any question, I will stop
thank
here
you
because of the time, but I would like to share with you something. Give me a second.
Okay. Thank you very much, Doc. Very exciting presentation. I'm sure those practicing with an interest in PEDS found it to be very interesting. Beautiful cases. We've been very privileged to get this presentation. We have a few questions. I'll just skim through them. We are almost out of time. The first question from one of our dentists, if you go to the chart, the question is, what determines your choice of the veneered stainless steel crowns instead of the zirconia? Well, is there criteria you use to pick for the cases?
Well, I think we are talking about the case where I placed 2 stainless steel crowns, pre-veneered stainless steel crowns on the lateral incisors and zirconia crowns on the central incisors. That is a very interesting question, and I was waiting for somebody to ask me that question. The reason why I placed steel crowns, the reason why I did that combination was before. That was one of my first clinical cases using zirconia crowns when I was learning to use them. That kid was treated under general anesthesia, and I was spending a lot of time trying to place the crowns of the lateral incisors. The crowns of the central incisors were already cemented, and I was spending a lot of time trying to adapt the crowns of the lateral incisors because I was just learning to do that kind of new restoration for me at that time. So I remember that I had some steel crowns, some pre-veneered steel crowns, and so I took those steel crowns and I decided to place them on the lateral incisors, and that was the way I restored them because of the time I was spending under general anesthesia. Finally, that was very good because I had the opportunity to compare 2 different dental materials, 2 different kinds of restoration in the same mouth.
Thank you. Thank you very much. The next question, I had a few questions around some of the teeth looked really short on the anterior restorations. So do you ever get any problems with retention? A related question there is, how do you control gingival bleeding during the cementations for those subgingival margins?
Okay. Controlling gingival bleeding is a very important step when we are placing any kind of restoration, especially zirconia crowns, because, okay, it's very important to control gingival bleeding. There are different ways to do it. The most common use is just with a wet gauze, doing some pressure on the tooth before cementing the crown. That works very well. But in some cases when it is very difficult to control humidity, we can control gingival bleeding using something called Viscostat Clear. Viscostat Clear is aluminum chloride. It's from Ultradent company. You can just apply Viscostat Clear for 20 seconds and then you rinse, and the gingival bleeding will stop. About the retention of the crowns, as you saw in all my cases, zirconia crowns must be placed at least 1 millimeter subgingivally. 1 millimeter subgingival is the recommendation by the manufacturer. And placing the crown subgingival, you will get more retention area to hold the crown. And of course, using a high quality cement.
Thank you. Thank you very much. I think
welcome.
I'll take the last question. One of the things we noted on your MIH cases, you're using a lot of pulpotomies there.
Yep.
is it because the teeth were immature, or I think I just wanted to clarify that what determines the decision. And the last question, I'm running slightly out of time, is for sensitivity. Are you using SDF in any of your treatments, or you haven't found it necessary to use that technique?
Okay, SDF works very well to control sensitivity. You can combine SDF and then you can place the restoration, the final restoration a week later, 2 weeks later. That is a good way to do it. About pulpotomies, why do I do a lot of pulpotomies? Because my clinical practice is basically on kids. And I see every day in my clinical practice, I treat kids, 6, 7-year-old kids with MIH, and the molars are partially erupted and the apex are open. So a good way to preserve pulpal vitality, to promote the closure of the apex of those teeth, is preserving pulporum, preserving vitality. And the best way for preserving vitality is not communicating to the pulp, or communicating and doing a pulpal treatment using a bioactive materials as MTA, as biodentin, etc.
Okay, thank you very much. I think that will be our final question. I'll just take the opportunity to thank you again, Doc. More people, I think those who are interested can continue following you on the Molar Incisor Hypomineralization Forum. It's very interesting. Thank you for all the articles and cases we see there. Otherwise, we will wish you good luck and hope to meet you one of the congresses. Otherwise, best of luck and thanks so much.
Thank you very much for the invitation. Feel free of sending me an email if you need foreign information, if you need an article, or anything you need. And feel free of asking me any question, any doubt that you have through my social media. Thank you very much for this invitation. And good
Fantastic.
night.
Thank you,
Good
Doc.
night, good night, colleagues. Just to remind you, we still have one more series of lectures tomorrow. Interesting one. Please join us. Otherwise, good night, everyone.
Good night. Bye.
Bye.
Thank you.
Thank you.